All right, hi guys. Today we're going to talk about two neurology topics, anti-epileptic drugs and headaches. Okay, my Facebook apparently needs to notify me during this. Sorry. um, these are probably two of the more common neurology topics that have more of a medication-related treatment. So I'll start with epilepsy. Epilepsy is, of course, a very specialized area of medicine, and most epileptic patients are going to be following with an epilepsy specialist or neurology specialist. So as far as the management of it, probably not as big of a deal, but I think it's important to understand the drugs because you'll probably come across patients because it is a disease that affects children and young adults. So definitely, your patient population of generally younger women very well could have epilepsy, and I think you'll come across it at some point in your practice. Just some statistics there for you on the slide. One thing I will point out is that when we talk about we'll talk about the different drug therapies. It's not uncommon to see people on a couple different, maybe 3 or 4 different anti-epileptic drugs. About half the population with epilepsy can be managed with one drug alone. So that's a pretty good number actually compared to like when we were talking about depression yesterday. Or not yesterday. Well, I was talking about depression yesterday. You guys are watching it at some point. So ultimately, it's a treatable illness, but sometimes there are very resistant cases where you have to give multiple drugs, and that can affect quality of life potentially. Seizures kind of fall into three categories. I think there's epileptic seizures, which involves a hypersynchronized system of neurons throughout the brain overreacting to some sort of stimuli. Whether it and what exactly is causing that stimuli is kind of unknown with epilepsy. And epileptic seizures can be involved the entire brain. They can just be very focal too, or what we call partial seizure. Provoked seizures are anything from drug overdoses, metabolic changes, brain tumors, strokes, something that's happening in the brain. It's non-epileptic, but is affecting the way neurons communicate that's going to cause a seizure. Pseudo seizures are a physical manifestation of some sort of psychiatric illness. So usually people who have anxiety, maybe severe anxiety attacks. It's kind of a rare syndrome, but it is something that does happen. And the problem is that it looks quite a bit like an actual seizure. So people will present to emergency departments or something like that with seizures, and they might get an epilepsy workup when ultimately all this work is done to find out that they just have pseudo seizures, and pseudo seizures can't be treated like a regular seizure disorder. Nothing will work for it. You really have to treat the underlying psychiatric condition. And that's all I'm really going to talk about with pseudo seizures. EEGs can be used as diagnostic tools to determine if a patient's having like a pseudo seizure or an epileptic seizure. They can look at specific patterns on EEGs to see if it's epileptic form or not. Generalized whole brain, partial, focal, small parts of the brain. A generalized seizure is, I think people historically think of like a grand mal seizure or a tonic-clonic seizure. That's your generalized seizure, but they can apply to multiple different spots. So you could just have a clonus, you could just have tonic components of it. Absent seizures, we'll mention very briefly. And then there's partial seizures, simple, complex, basically relating to how aware you are of the seizure itself and whether you know you're having a seizure. Partial seizures are the most common, making up almost 2/3 of the seizures we see in patients. And then there's generalized seizures making up the other part. Phases of seizures and classification is here just for your reference. If you want to review it, go for it. I'm not going to ask anything on a test about this stuff. So drugs, the drugs are going to be broken up into some of the major, more common drugs, and then I'm going to talk about some specifics with those. As far as mechanisms of action, I've just got them all kind of lumped together in this first one. Basically, there's two mechanisms of action, this one being the more common general pathway. That's working on the excitatory synapses in the brain and basically inhibiting their ability to overreact, to overexcite. And the way we do that is with a variety of different pathways. But you can see the most common one, where most of these drugs are acting, is the voltage-gated sodium channel. So it's a sodium channel blocking agent, blocks these sodium channels, which prevents the depolarization and release of various neurotransmitters that this neuron is using to communicate and cause an excitatory response. A couple other medications work a little bit differently. Gabapentin and pregabalin aren't very effective for seizures, so we won't talk about those right now. Felbamate works by blocking some potassium channels, potassium chloride, sodium transporters. and then Topiramate also works on some other receptors as well. So you have some medications that work on the process similarly, but they're basically blocking the effects of the excitatory synapse from occurring versus blocking the excitatory process from even starting, like a sodium channel blocker would do. Then you have Levetiracetam or Keppra, which has sort of a little bit of a different mechanism where it prevents release of vesicles in the synapse itself. So again, very similar. Ultimately, the end byproduct is the same, but you end up with a bit different of a mixed mechanism here. The other side of the coin is you can promote inhibitory response within the brain. And there's a bunch of drugs that do this. These drugs are not as commonly used. And you can see we have some bleed over here. Felbamate, Topiramate, Zonisamide. And on our other slide here, you can see Felbamate and Topiramate work. Zonisamide is also a sodium channel blocker. Some of our medications do have multiple mechanisms. And other ones, more potent ones like benzodiazepines and barbiturates, which are used mostly, but benzodiazepines are kind of the gold standard for acute seizures. So like a status epilepticus, a seizure that's not responding to anything or is prolonged. Barbiturates have been used historically, but are rarely used anymore. They're heavily sedating. They just have a terrible side effect profile, and they cause quite a bit of respiratory depression if you take too many of them. So let's start with Levetiracetam or Keppra. Keppra is a broad-spectrum AED. On these slides, I'm going to put what they're FDA approved for and what they're used for in real life. I'm more concerned about the real-life indications. Keppra is broad-spectrum. It's used for every type of seizure. Maybe not in absence, but it's still maybe effective. It doesn't have any drug interactions, no side effects. Comes oral, well, minimal side effects, I should say. Sorry, not no side effects. Comes as an oral product and an IV product, meaning you can load people up with intravenous medication if they come in and their Keppra level's low or they've been off their Keppra for a few days. Or we also use Keppra for acute seizures too. Because if you give somebody, like I just mentioned, benzodiazepines like Ativan and Valium, or diazepam and lorazepam, work well to stop seizures in the acute phase, but you need to be thinking about what you give a patient long term. So a lot of times we'll start Keppra at the same time, or in fact, high doses of Keppra IV have been shown to stop seizures on their own too. So Kepra's got a lot of nice utility in the acute care setting and in the outpatient setting. It's twice daily dosed. There's an XR formulation that makes it once daily, so there's some option there for maybe a more convenient dosing. Renally eliminated. Two major side effects to think about. One is sedation, which can mostly be avoided if the patient slowly titrates the medication. So if you aren't starting on a really high dose, you shouldn't really see much sedation. The other side effect is behavioral related, and it can happen in up to 10% of patients, depending on what studies you read or what side effect you're looking at. But it's sort of a variety of symptoms. You can see anger, aggression, irritability in patients that don't otherwise have that. So it's something to be aware of and make sure patients are aware of. So if they start feeling really irritable after they start Keppra, that could be the reason why they don't feel like they're, going mentally ill or something on us when we can't, and they're going to be maybe feeling like their life is out of control when it really could just be a side effect of the drug. But it's a relatively rare side effect. It's not a reason not to use Keppra, and even if you have underlying maybe history of mental illness, depression, or anxiety or whatnot, it's still not a contraindication or precaution to using Keppra. Lamotrigine or Lamictal is another broad spectrum AED. Works very well for multiple seizure types. It's kind of like Keppra, where it's really, really well tolerated. It doesn't actually have many side effects. Most of them are dose related. Usually you can see them when you get to higher doses, like tremor, maybe some dizziness and some movement disorder. It's once daily dose, got a nice long half-life, not renally adjusted. This is pretty much the drug of choice in pregnancy. I'll talk about pregnancy in a moment on a further slide, but it is basically considered to be the AED of choice to use for pregnant patients. Biggest con of lamotrigine, you have to titrate it slowly. It has a rash reaction that is pretty common if you don't titrate it correctly. And even worse, it is associated with Stevens-Johnson syndrome, which is a syndrome, if you aren't familiar with it, where the skin, it's a autoimmune it's a hypersensitivity reaction, usually to some sort of drug or substance that you've come in contact with, and it's very unpredictable. But lamotrigine does have a fairly high risk of Stevens-Johnson's if you don't titrate it correctly. So you have to start really slow with lamotrigine. There's very specific titration guidelines for lamotrigine, and just make sure they're being followed appropriately. If you're in a situation where a patient comes into your clinic, they were on lamotrigine, maybe they've missed a week or so, generally speaking, if you've missed more than 4 days of lamotrigine, you have to retitrate from the beginning. That's something that actually comes up quite a bit. If people stop this medication, what do you do? And that might be a question you get from a patient. I was on lamotrigine and ran out. I'm here to see you because you're my primary. Now, what do I do? And just know that if you remember one thing about lamotrigine, just remember it causes a rash and you shouldn't dose it very quickly. And make sure you're following specific titration guidelines, which should be available in any drug database you look at. They should be very specific on how to dose lamotrigine. Drug interactions, not as big of a deal on paper. However, clinically, we've seen some drug interactions with lamotrigine, so it is something to be aware of. Keppra really is the only drug we're going to talk about that has no drug interactions to be concerned about, which makes it a really great therapy again, and something, if you haven't started somebody on Keppra, or if somebody's not already on it, it's a great add-on therapy because it won't affect what they currently are taking. Whereas virtually every other anti-epileptic drug, if you add it on to somebody else, another regimen, it's going to have some sort of an effect from drug interactions. Valproic acid, or Divalproex, or Depakote, is kind of considered a gold standard of anti-epileptic drug. It's a new-ish anti-epileptic drug. It's very effective. It's a broad spectrum agent, and the pros, it has some IV. It has an IV form called Depakon, so you can dose it IV. You can get, just like with Keppra, you can use it in acute situations. You can use it to get people's levels back up. It's actually got, and we're going to talk about it a little bit with migraine too, but it's got a little bit of use there too. It is contraindicated in pregnancy as a 1 to 2% chance of spina bifida above the normal population. It's got a lot of drug interactions to consider. Side effect profile isn't great. It causes tremors, alopecia in both men and women, up to 25%, weight gain, usually undesirable side effect there, and some blood dyscrasias. So regular monitoring is important with valproic acid. So while this is a really effective medication, it's sort of fallen out of favor as a first-line therapy because of its side effect profile. Keppra, or Levetiracetam, and lamotrigine just have better side effects and better tolerated, so they've kind of taken the role of valproic acid. Topiramate is another broad spectrum agent. Weight loss is one of the things that happens with topiramate, so it could be a pro if you have a patient who could maybe stand to lose a few pounds, maybe an overweight diabetic patient potentially. Cons, Topamax is a brand name. It's also referred to lovingly as Dopamax. One of the biggest side effects to remember about Topamax is this slowed thinking and speech difficulty, which can happen in up to 30% of patients who take it. People just tend to feel kind of dopey, and that's why it's called Dopamax. Obviously, a problematic side effect for most people. Not everyone's going to get it. Again, it's a 30% reported incidence, but it's something to be aware of. Patients reporting that they just don't feel like they're processing information like they used to be, or feel like they aren't speaking clearly or not speaking as eloquently as they used to. Phenytoin is Dilantin. It's another very effective, commonly used broad-spectrum AED. It's one of the oldest medications that we still use fairly regularly currently for epilepsy. It's got some issues with it. It's effective, very effective, but it's got a fairly narrow therapeutic index. I'm going to mention the kinetics on another slide here shortly. It also is pretty nasty when it comes to drug interactions. It's an inducer, meaning it ramps up enzyme interaction, so it can process medications a lot faster. So a lot of times if you're taking other anti-epileptic drugs, there are recommendations that you actually may need to increase your dose a little bit if you're taking phenytoin at the same time because of that enzyme induction. Side effect profile, hallmark, overdose, not necessarily an overdose, but maybe slightly above therapeutic range. Nystagmus, slurred speech, and ataxia. Dizziness and drowsiness, hirsutism, aka growing of hair in places you don't want it to grow. Gingival hypertrophy, overgrowth of the gums, hypersensitivity, hyperglycemia, teratogenic. There's a lot of problems with phenytoin. It's not a well-tolerated medication overall, but it is very effective, so we still do see it being used quite frequently. Carbamazepine and oxcarbazepine are the last two really common ones I'm going to talk about. Carbamazepine has kind of fallen out of favor. It's the older version as an AED, so oxcarbazepine will be much more popular. Carbamazepine's gotten a lot of use in like indications like neuropathic pain though, and some other areas too. So you do see it used maybe off-label. Also in bipolar disorder, I think I maybe mentioned it in the last lecture with respect to that. Side effect profile, they both share hyponatremia, can both cause a rash. They both cause drowsiness and dizziness, blurred vision, maybe some GI side effects too. I listed rash twice, apparently. I thought it was really important. Carbamazepine has some problems in pregnancy. It also has some blood dyscrasia issues that oxcarbazepine does not. Some other agents that I'm not going to talk about a ton because these aren't as commonly used. Zonisamide is a fairly broad spectrum agent that this one I still have on this other slide, but it probably could use its own slide maybe at this point. It's getting more commonly used as a good first line option actually. It is brand name only. It is probably one of the more expensive drugs, so that's probably going to limit its role, but as an adjunct agent or again, it's a good broad spectrum agent that seems to be pretty well tolerated by patients. Here's some agents for partial seizures. Again, I'm not going to spend a ton of time on these. For monitoring levels, usually what you're looking at is a trough level. So with newer anti-epileptic drugs, really all we're doing is seeing if a patient's taking the medication. So if you have a patient in your clinic or in your practice who is on anti-epileptic drugs and maybe they aren't the most adherent and you're a little bit worried if they're taking their medication or not, what you can do is check a level. And if it comes back normal, it's probably a good indication they're taking their medication. If it comes back really low, probably they maybe missed a few doses here or there. So usually we use it for adherence purposes only. The newer medications have such a wide therapeutic index that there's no real good recommendations on therapeutic range and efficacy. So it's not like we're trying to target a certain level. Older AEDs, we might change our minds with this. And the only one you have to think about as being different is phenytoin. Remember, it's got a narrow therapeutic index. It's really highly protein bound. So if somebody takes too much of it, what happens is that your protein, your albumin in your bloodstream can only bind up so much phenytoin or so much drug in general. So if you displace it or if there's too much in your system, you can get really high free levels. What happens is the kinetics end up being exponential. So most drugs, kinetics are predictable. So if you take a dose of Keppra, you should get a linear response. So if you double your dose of Keppra, you should get a double in the plasma concentration. Phenytoin, you get to a point where if you double your dose, you could end up like quadrupling or quintupling your blood concentration. So you have to be really careful. Dose increases with phenytoin should involve some sort of monitoring too. Gabapentin and pregabalin are both kind of anti-epileptic drugs, and they may be used sometimes for adjunct therapy and partial seizures, but really they're more so used for neuropathic pain, and they don't have much of a role in seizure use anymore. And that's all I really want to say about that. Some newer drugs just on the horizon. Probably the big two to watch are this Carbamazepine, which is kind of like oxcarbazepine, but it's supposed to have a bit different of a metabolism pathway, and so it should have a blunted peak effect and maybe a bit longer duration of action in the body. Maybe minimizing side effects yet still retaining efficacy. Levetiracetam is Briviact, and this is a medication that just came out. It's a Keppra analog, and it's sort of like a more potent version of Keppra. So I think that one's probably going to be one we're going to be seeing a lot of in the next few years, but we'll see. We'll see what happens with that. So when you're treating somebody with epilepsy, really you have to assess a couple things. First of all, when they're coming into your clinic or when you're meeting with the patient, what are they already on? Are they already on an established regimen? I would be very cautious at tweaking somebody's established regimen unless you have a really good reason to. And make sure you're conferring with whoever their epileptologist is or their neurologist is. And it should be a collaborative effort there. You might see some odd things done by various epileptology groups. And that's because sometimes in problematic cases, it can be really challenging to manage people's seizures. So you might see some creative options taken. So just be aware that that's something that should be collaborated with. And I think you guys probably know that. If you had a new patient who was, started on something, just know, I guess, having a good sense of what the first line options are, even though you wouldn't necessarily be prescribing them, knowing kind of what is normal and what to look for. And I think what you're going to see a lot of is Lamotrigine, Keppra, Depakote, Topiramate, maybe some Zonegran coming in, maybe phenytoin, and maybe Oxcarbazepine. It's probably the medications to know the most about and to be the most familiar with. Because a patient comes into you and complains about side effects, you should be aware of what medication could be potentially causing those. Patients can go off seizure medications. There are some recommendations that if you've been seizure-free for 2 to 4 years, you can consider tapering off your medication. Now, this would depend on a lot of factors: how well controlled the patient, or how severe the seizures were to begin with, how hard it was to get the patient controlled. Could be a lot of problems with taking somebody off of an anti-epileptic, so it really is a risk-benefit scenario, but making sure that you're evaluating that. Partial seizures are a very similar treatment pathway. Absence is very similar as well. We do take a drug called ethosuximide and use it for absence. Absence is more common with young adults and children and adolescents than with older people. So you might see it in maybe your younger patient populations. But ethosuximide kind of takes a role as a first line here. It's an unusual medication that's only for absence seizures. So pregnant patients, with pregnancy and epilepsy, there has been some, basically, historically, what we know for sure is that epilepsy, uncontrolled epilepsy, is bad for pregnancy. So if you don't give somebody any medication at all and they risk getting a seizure, that's harmful for the developing fetus. So historically, people have just been taking whatever they've been on that's controlled their epilepsy during their pregnancy. There's been a variety of studies. One really big one and well done one that came out of, I think, Denmark a few years ago, looked at some national health data for like a big time period, several years, looked at a lot of patients who were on anti-epileptic drugs and underwent pregnancy and the correlation between that and side effects or birth defects. And they found that patients on newer anti-epileptic drugs had much lower incidences of any complications with pregnancy or birth defects than people on older anti-epileptic drugs. So the newer ones that were Lamotrigine, Levetiracetam, Topiramate, and Oxcarbazepine. So those are probably the 4 to stick to. The tricky part gets is if you have a patient who comes in who's on Divalproex and is meeting with you because they want to start a family or they are pregnant, that's something to discuss with their neurologist or epileptologist. Is it worth switching at that time because of the risk of spina bifida with the Divalproex? But if they're really well controlled with it and not having any problems, is it worth switching to like a Lamotrigine? And that's a tough question, but it's going to be definitely a conversation to have with multiple people to see what the best option for that patient would be. There's some questions about why the new drugs are better. Well, I think first of all, they control epilepsy better, and patients are more likely to be adherent with them because the side effect profiles are better. I think that's a big theory as to why they're just better in general. Other drugs just have a poor side effect profile too, so like phenytoin and Divalproex just aren't as well tolerated. Carbamazepine having some problems with possible teratogenic links. So the question is, what's the real underlying reason why newer drugs are better? And I think it's probably a combination of both. I think you have better tolerability and better side effect profiles that don't affect the developing fetuses substantially. Children, you can use pretty much any anti-epileptic drug that you can use adults and children. Lennox-Gastaut's kind of a rare childhood thing that I'm not going to talk about here. Brand name versus generic is kind of an interesting debate too with anti-epileptic drugs. There was some legislation proposed in Minnesota a few years ago that wanted to exempt epileptic drugs, anti-epileptic drugs, from the laws that allow pharmacies to automatically generically substitute medications. So for example, let's say you write a prescription for Prozac, and you write Prozac on your prescription pad. Or, everything's electronic now. But let's say you're going old school and you're actually writing out a prescription. So you're going to write Prozac on your prescription pad, and you take that to the pharmacy. The patient takes it to the pharmacy. They fill it. they're going to get fluoxetine. They aren't going to get brand name Prozac unless you prescribe it DAW. Or dispense as written, in which case you're going to get a call from the pharmacy asking why on earth you want DAW Prozac. So the legislature wanted to make it exempt that if you prescribe Depakote and you bring it to a pharmacy, that pharmacy has to fill brand name Depakote. They can't fill Divalproex generic. So that was going to be a big problem with a lot of insurances. Pharmacies would have been under a lot of pressure to be able to have to fill these, and it's a lot of work to have to get a prior authorization. You have to go back and forth with the clinic. As the provider, you have to do paperwork. It's not easy to do. It would have been a headache. Fortunately, it didn't pass. Now, the question is, why did this even come up in the first place? And the reason being is that there's variances between the actual amount of medication within each tablet. And I don't know if Katrina talked about this, or maybe I talked about this at the beginning. I can't remember. But the FDA allows up to 80 to 125% variance for prescription products. So if you get a 100 milligram tablet that says 100 milligram on the bottle, that could have 80 milligrams in it, or it could have 125 milligrams in it. Now, most drug companies have much more stringent standards than what the FDA proposes. So like I used to work for a pharmaceutical company, and I believe our specs were anything from 90 to 105% was within spec. It's been a while, so but it was, the point is, it was more stringent than the FDA's recommendations. So with that being said, the question is there really a big enough difference to matter? And I don't think there probably is. It kind of is like what I mentioned with synthroid medications and switching between brands. You can have subtle differences that end up causing a big effect. And this is kind of the case with anti-epileptic drugs too, potentially. Let's say you're taking Keppra and you've been on 1,000 milligrams twice a day for a long time. And maybe the 1,000 milligrams you've taken has actually been 900 milligrams, and you haven't noticed, because how would you know that? And it's been working for you. Then all of a sudden you get switched to a medication that is 1,100 milligrams, because it's a different manufacturer. And then you start to have side effects. Maybe you start to feel irritable. That's a 200 milligram difference per day, which over time could make a difference. And on the other end of that, if you're taking less than you're used to, 200 milligrams less a day, could be at risk for decreased efficacy. So there is some concern, but clinically, I really don't think it's panned out. I think it is generally recommended that you stick to the same manufacturer if possible, but definitely don't avoid generic medications with anti-epileptic drugs. This is just for your information. If you're interested at what drugs lower the threshold of seizures or increase seizure risk, a lot of these aren't super common. Antibiotics, all beta-lactam classes of antibiotics in excess can increase risk of seizure. Bupropion or Wellbutrin can lower the seizure threshold. So if you take too much Wellbutrin, we'll see seizures. Those are kind of the big ones. There's some other ones here too. And again, in case you're interested, you can check that out. All right. Take a break if you want, and you can come back and listen to me talk about headaches if you don't have a headache already. It's my joke for the day, I guess. Okay, so I'll get right into headaches, and we're going to focus mainly on migraine headaches. There are a bunch of different types of headaches: tensions, nerve pain-related headaches, daily chronic headaches of various types, and of course, lots of things could cause headaches: brain tumors, trauma, sinus pressure, hemorrhage into the brain. Of course, that'd be more severe, but you guys get the point. There's a lot of potential other pathophysiology that can lead to a headache. But a migraine is a neurologic disorder. It's an episodic disorder. It's a severe headache associated with nausea, light, sound sensitivity. It's pretty common. It affects up to 12% of the population. So it's by far the most common neurologic complaint. And it's more common in women than men, excuse me. So for you guys working mostly with younger women, you will undoubtedly encounter many people throughout your career who have migraine or struggle with migraine, and it can be really challenging to manage them. So we're going to walk through some of the treatments and what we consider doing as far as what's kind of the first-line therapies and second-line therapies and such. 4 phases of a migraine. I think a lot of people think people with migraines always get an aura or a prodrome, and I think it's important to know that you don't actually get that with a lot of people. People who have that probably are a bit fortunate, because if they have an aura and some sort of visual disturbance or they smell something or whatever, that can be a good indicator that they know they're having a migraine or that migraine's coming. They can take medication immediately, possibly stop the migraine from occurring altogether. People with aura are at a little bit of an advantage. Prodrome is a bit different because it can happen days in advance. So if you get a prodromal effect, you don't necessarily have the knowledge. You don't have the time frame, whereas an aura is usually right before the migraine would actually occur. So basic treatment. Really, it's important to think of migraines as start treating it like any other pain syndrome. Don't ignore your basic over-the-counter medications. While the odds of them working substantially might be kind of slim, they're still definitely worth a shot. So acetaminophen, basic Tylenol, give it a try, and if it doesn't work within a half hour, you know that it doesn't work. Tylenol doesn't take days to work. It takes, as soon as it gets absorbed, you should be getting some relief if it's going to be effective. So the important part to remember to know is to not be wimpy on your dose. So use a decent dose. Use a gram of Tylenol. If you're using an NSAID, use higher end dosing of your NSAIDs. NSAIDs are probably likely to be more effective than Tylenol, so ibuprofen, naproxen. Again, you can try all this stuff. Aspirin, I don't really like aspirin as a pain reliever because with the pain lecture, remember that it causes a lot of dyspepsia at higher doses. These clinically, especially with NSAIDs have been shown to relieve headache, pain, variety of different types of headaches. While migraine might not be the best, they might not be the best for migraine, they still are probably worth a shot. And again, it's kind of like Tylenol, where if you take them, you should have effects relatively quickly. The effects are peripheral, centrally acting analgesia via mostly anti-inflammatory processes, or decreasing inflammatory processes. Basic combination therapies, we have the over-the-counter product, Excedrin, which is acetaminophen, aspirin, and caffeine. It's 65 milligrams per caffeine per tablet. So this is really the major new medication we're introducing here, and likely probably the more effective one, where the acetaminophen and aspirin probably aren't at high enough doses to really do anything. It's probably the caffeine that really is doing the trick here for most people if they respond well to Excedrin. Caffeine works as a centrally active vasoconstrictor. So I kind of glossed over this in the beginning, but theory with migraines historically has been that you have a vasodilation problem in your cerebral vasculature, meaning for some reason you're dilated, and by constricting down that dilation, it can help with the pain process. Likely much more complicated than that. There's likely a lot of neurotransmitters involved, increasing your susceptibility to pain response, as well as the vasoconstriction, vasodilation theory. Caffeine would purely be a vasoconstrictor. It does appear to work for some patients. There's another product called Fioricet, or acetaminophen caffeine butalbital, that also comes plus codeine in some cases, which would be a controlled substance in that case. But it's got the addition of a barbiturate, which is the butalbital, and this is prescription only. This one's not over the counter. But this product is basically going to be the same thing, but it's going to have a sedative component to it too. So you're stimulating yourself with caffeine, but sedating yourself with the butalbital. I don't know. I don't think a lot of people take Fioricet anymore. And those who do are probably not managing their headaches very appropriately, in my opinion, but it does seem to work for some people. Other products, there's a product called Midrin, which was off the market for a while, and I think it's back on now. It's acetaminophen and these two really odd drugs, dichloralphenazone and isomaheptine, and they're respectively a sedative and a vasoconstrictor. And beyond that, I don't care anything more about them. This is kind of funny. If you ever go to a store and look at Excedrin versus Excedrin branded migraine, they're the exact same product. There's nothing different about them. They have the same active ingredients and same strength. It's just marketing. It's actually kind of annoying that they can market that way, because it doesn't make any sense to market the exact same product two different ways. Really what you're doing is you're tricking consumers into thinking, well, I tried Excedrin last time, it didn't work as well, so now I'll try Excedrin migraine, and then you realize, whoops, it doesn't work as well too, because it's the exact same medication. Triptans are the well, they kind of are a newer class of drug, I guess. They haven't been around all that long, but they're a new drug for us. We haven't talked about them yet. They are serotonin 1B, 1D agonists. So they agonize serotonin receptors specifically in the central nervous system that have been seemingly associated with pain response. By agonizing them, you tend to propensate serotonin's mechanisms in the central nervous system, which seems to blunt the pain response. So what happens is this causes a downstream effect. By agonizing these serotonin receptors, you decrease the release of different vasoactive peptides, which can decrease inflammation and vasodilation, which also promotes vasoconstriction. And ultimately, you can block pain pathways by working with the serotonin as well. Triptans are really unique in their mechanism to migraine headaches. They don't really work for any other. So like if you take a triptan for a tension headache or a sinus headache, probably aren't going to get really any relief from it. It really needs to be a migraine-specific headache. There's 7 available triptans, a lot of different formulations. They're all pretty effective. We'll talk a little bit about some of the differences here. Here's a table comparing them. I don't have any of the brand names on here, just generic. If you want to know specific brand names, you can Google them. But what I've got here are just some comparisons that I'd point out. One thing I'll say is that most of these products are oral. The only one that comes as a sub-Q injection is Sumatriptan or Imitrex. And that's got the fastest onset of all the medications. So you can see here your Tmax in hours. You got 0.2 hours here, way faster than anything else. So sometimes patients who really need that fast onset, Sumatriptan sub-Q is the best option. We don't have anything IV in the triptan drug class. There are a couple nasal sprays. You can see their onsets maybe a little bit faster than oral. And then some of them come in ODT forms too. Interestingly enough, the ODT forms, like if you look at rizatriptan here, ODT is actually a longer onset than oral tablets. So I don't know if they're formulated for people with nausea who don't want to swallow a pill, and maybe dissolving the tablet and swallowing that is better. They do seem to have a longer onset, which is kind of interesting. I don't know if it's the formulation that's affecting that or what, but it's an interesting side note. All right, so Sumatriptan or Imitrex is by far it's the oldest triptan. It's the most commonly used one. And again, sub-Q Imitrex has the fastest onset of action. Now, with these fast onset of action of sub-Q, you also get side effects. People who take triptans have flushing, weakness, dizziness, drowsiness, and that's usually fairly blunted if you take it orally because it's absorbed slowly and released slowly. And compared to sub-Q, where it's released fairly quickly, you end up with a pretty big burst of medication, and all of a sudden you have flushing and some headache, or not headache, but weakness. And usually it resolves fairly quickly in about 30 minutes. Sumatriptan is generic, but it is brand only when it's combined with naproxen. Why you'd ever prescribe that combination product, I have no idea. Just give somebody generic Imitrex and then have them get naproxen over the counter. It'd be way cheaper. Patients who don't respond very well to one triptan may likely respond well to another. So talking about some of the differences, they've done some head-to-head trials, but there's not much information out there. And most of the head-to-head trials have found that there's not really any clinical difference between them. Rizatriptan, which is Maxalt brand name, has the fastest onset of any PO medication. So if you're looking at oral medications purely, could be a better option for some patients. Naratriptan and Frovatriptan have a slower onset, but they also have a longer half-life. So while clinically, actually, they've seen a lower efficacy rate as far as stopping a headache because of the slower onset potentially, they've shown that these medications may be more effective in the long run because they don't wear off as quickly, so they prevent a rebound migraine from occurring. Interestingly enough, so if you have a patient who's responding well to to a shorter acting triptan, and but they're getting a headache coming back, a few hours after they take it, try one of these longer acting ones. It might be enough of a sustained effect where it prevents that from happening. Again, side effects I kind of talked about. Warnings: you don't want to exceed the recommended amount per day. These medications are relatively safe, but if you take too much of them or combine them with ergot alkaloids, which we'll talk about in a second, you end up running a risk of what we call vasospasm within the coronary vasculature and the cerebral vasculature, which can cause stroke-like symptoms or heart attack-like symptoms. So make sure you're watching your amount. Like, for example, Sumatriptan is a max of 200 milligrams oral a day, and it applies from all sources. So, for example, if you have a patient who comes in and says, I took 100 milligrams of Sumatriptan and my headache's not gone. Can I get a sub-Q injection? And you have sub-Q injections in your office, so you say yes. Well, 6 milligrams of a sub-Q injection is essentially equivalent of 100 milligrams oral. So you need to know what your max is. So if you give that 6 milligrams, you're done. That's it. That's all you can give for triptans in the day. You don't want to give any more than that. So just be aware of what you can do with that. If you're going to give ergot alkaloids, DHE is the medication here. It's really only ergot alkaloid. It comes IV, IM, and sub-Q intranasal. It's a bit more potent than a triptan, and you can give it IV, so it can be at much more fast onset than even the sub-Q Imitrex. The important thing to do if you're ever thinking about DHE is make sure to ask your patient if they've taken any triptan. If they've taken triptan within the last 24 hours, they can't have DHE, and vice versa. If they got DHE, they can't take a triptan for 24 hours. And again, it's at risk of vasospasm. Ergot alkaloids have very similar mechanism of action to triptan. They're essentially a slightly less specific and more potent version. Antiemetics are very useful for migraines, not only because they can help with the nausea component of it, but they actually have been useful for stopping the migraines on their own. I didn't do a specific lecture for you guys on nausea. I'm sure Katrina touched on that at some point, I think, maybe, or if not, I'm sure your book has a good chapter on it. But there's a class of antiemetics within the within the group of antiemetics, the class called dopamine antagonists. And these are actually very similarly linked chemically to our first generation antipsychotics, like I talked about during the psych lecture. So like haloperidol is a dopamine antagonist. These medications are very similar. So we have metoclopramide, prochlorperazine, chlorpromazine, and droperidol. Droperidol has been on shortage for years. Who knows if we'll ever see it again. But compazine and Reglan, and maybe some degree Phenergan, work very well for headache control, and they're also great antiemetics as well. So you get a double mechanism of action there. They are effective as monotherapy. Some people will go straight to them and avoid, especially if a patient's come in and they've tried a couple doses of triptan. It's a good medication to try because it's a different mechanism. Caution with that movement disorder. Remember your EPS and QTC prolongation also with these medications. So may need some monitoring with that. Other options, IV or IM ketorolac. I mentioned this during the pain lecture, but very potent NSAID. This is a great option to try for headache. IV caffeine or PO caffeine for that matter. If somebody hasn't tried caffeine, you could try PO caffeine. I'll talk about the problems with caffeine in a moment, but IV caffeine might work. Valproic acid IV infusion, Depicon infusions, those are very effective for stopping migraines. Steroids, actually, two high-dose steroids, high-dose methylprednisolone and dexamethasone have been shown to be effective for migraines, giving it over a relatively short interval. And then ultimately, you never want to end up here, but opioids would be effective for migraine headache. You just want to avoid having to use them if you can. All right. So our first line are simple analgesics. Second line, you go to your triptans, DHE, and antiemetics. Third line, valproic acid, steroids, and narcotics, and kind of in that order, with narcotics being probably maybe a fourth line option on its own tier. Medication overuse headaches are caused primarily by using too much caffeine products, too much Excedrin, or drinking too much caffeine itself, and opioids. Opioids are notorious for medication overuse headaches. Usually what happens is you take too much of the medication, you stop, and it's sort of a withdrawal effect. Triptans and NSAIDs don't seem to have as big of a risk, so just be careful. Again, that's why caffeine products are a little bit hesitant to recommend them. If you're using them sparingly in PRN and once a week at most, that's fine. But every day you could get into trouble with that. Preventative medications are really important for people with migraine. Beta blockers and antihypertensives in general. Propranolol, metoprolol have been favorably studied. Verapamil is a really commonly used one. Not kind of fallen out of favor as a calcium channel blocker, but works pretty well for migraine prevention. ACEs and ARBs as well have been useful for just controlling the blood pressure aspect. Antidepressants like tricyclics and SNRI, specifically amitriptyline and venlafaxine, have been studied as preventative and have been shown to be effective. Anti-epileptic drugs like Valproic and Topiramate are used very, very commonly as migraine prophylaxis agents. And if you have a patient with chronic tension headaches that nothing seems to work, Botox actually has been used. You can inject Botox. You can see some of the different points depending on where the tension headache is, if it's in the neck or forehead or temporal region. You can inject Botox locally to paralyze the nerve and therefore relax the muscle and decrease the tension headache. I don't have a slide specifically on pregnancy, but if I go back here, I don't know if I mentioned it, but you can't use ergot alkaloids or triptans in pregnancy. I actually don't think I have it on the slide here. So you can add that in or just make a mental note of that or wherever you want, but they're contraindicated in pregnancy. And some antiemetics are more commonly used in pregnancy than others. I don't know how much Katrina went into detail, if she did at all, but Reglan is usually considered to be okay in pregnancy. Compazine may be a little bit less favorably researched in pregnancy. As far as our other options go, valproic acid we talked about the spina bifida risk, so that's a no-go. Steroids have some mixed reviews on whether or not they're okay to use. For the most part, with a migraine, if you have a really severe migraine patient and they're pregnant, you don't have a ton of options. NSAIDs are generally ruled out. Your triptans and DHE are ruled out. So you're looking at a very select limit. You're looking at a very selective scope of possible options. Steroids being one of those potentially that you could use. So if you have somebody with an uncontrolled migraine, a high dose of steroids might be enough to help them, and it's got a lot lower risk of any problems than fetal complications or pregnancy-related complications than valproic acid. It's not without any risk, and if you want to read about glucocorticoids, if you haven't talked about them in another lecture, I'd recommend looking at them because they're such common medications and knowing some of the studies. But there is I believe there's some slight evidence for cleft palate and maybe some cardiogenic malformations within the developing fetus with them, but it's very low risk and the evidence isn't great. Usually I think if you need to use a steroid, we are on the side of steroids are generally okay in pregnancy. Opioids we talked about, generally safe in pregnancy too. You just, again, want to avoid them, but sometimes you might have to go to them, especially since there's not many other options you can use in a pregnant patient. All right, with that, that's all I've got. So I know it's a really quick synopsis, and there's a lot more to neurology than migraine and epilepsy, but those I think are the big ones to talk about. That are probably the more common ones you'll see. If you have any questions, again, email me and let me know. Thanks.